Good morning. We are the Group 2 and we will be presenting genital infections, particularly syphilis, starting with the causative organism, the spirochete treponema pallidum. It is a slender, spiral-shaped organism with tapered ends. Immunofluorescent stain or dark field immunization is used for visualization. Drying kills the spirochete rapidly, as does elevation of the temperature to 42 degrees Celsius. Risk factors: women at highest risk are those from the lower socioeconomic groups, adolescents, early onset of sexual activity, and having many sexual partners.
For the clinical manifestations, syphilis can be divided into two, acquired and congenital. For acquired, it can be divided into three. Primary syphilis or early localized stage happens 1 to 3 weeks after T. pallidum lands on the mucous membrane. The hallmark lesion is chancre. It is an isolated non-tender ulcer with raised-rounded borders and an uninfected base. It may become secondarily infected and painful. Its mean incubation period is 3 weeks and it can develop 10 days to 3 months. Without treatment, lesions spontaneously heal within 6 weeks. Secondary syphilis or disseminated stage develops 6 weeks to 6 months after the chancre appears. Its hallmark is maculopapular rash, which involves the entire body. Mucosal lesions called mucus patches or actively shed spirochetes. Seen on genitals, anal region, and armpits are highly infectious plaques called condyloma lata. Because syphilis is a systemic infection, other manifestations may include fever and malaise. Less commonly, cranial nerve dysfunctions, meningitis, hepatitis, nephrotic syndrome, and arthritis can develop. During early latent syphilis, which is diagnosed within 1 year of infection, secondary signs and symptoms may occur. Late latent syphilis is a period greater than 1 year after the initial infection. Tertiary syphilis is a phase of untreated syphilis that may appear up to 20 years after latency. Gamma is a granulomatous lesion, which is a characteristic of the late stages of syphilis. During this phase, cardiovascular, CNS, and musculoskeletal involvement may become apparent. Congenital syphilis is a disease that occurs when a mother with syphilis passes the infection onto her baby during pregnancy. The baby may manifest deformed bones, severe anemia, enlarged liver and spleen, jaundice, brain and nerve problems. This is a table summarizing the clinical manifestations of the stages.
Good morning. For diagnosis of syphilis, we have two methods, direct methods and serologic methods. Under direct methods, we have dark field microscopy and direct fluorescence antibody testing. Treponema pallidum is a gram-negative organism and it is difficult to visualize it on a bright field microscope. On dark field microscope, it appears as a slender, spiral-shaped organism with tapered ends. For direct fluorescence antibody testing requires lesion exudates. Under serologic methods, we have two types of tests, non-treponemal and treponemal specific tests. Non-treponemal tests are non-specific and can be used as a presumptive diagnosis. It gives a false positive results under situations such as IV drug use, pregnancy, rickettsial infection, and endocarditis. And it can be used for population screening. The two important non-treponemal tests are venereal disease research laboratory test and rapid plasma reagent test. A confirmatory diagnosis with treponemal specific test is required. Two important treponemal specific tests are fluorescent treponemal antibody absorption test and treponema pallidum particle agglutination test. For treatment of syphilis, we give benzathine penicillin G as a first-line therapeutic agent, and the treatment regimen of syphilis depends on the stage of disease. For primary, secondary, and tertiary and early latent syphilis, we give benzathine penicillin G 2.4 million units intramuscularly as a single dose, and for penicillin allergic women, we give doxycycline 100 mg orally twice a day for 2 weeks. For late latent and tertiary syphilis, 3 doses of benzathine penicillin G 2.4 million units are given intramuscularly, and for penicillin allergic women, alternative drugs such as doxycycline 100 mg is given twice a day for 4 weeks. For follow-up after initial treatment, women are seen at 6 months after 6 months for clinical evaluation and serologic testing, and to assess the response to the treatment. Non-treponemal tests such as venereal disease research laboratory test and rapid plasma reagent test can be used. A four-fold dilution decrease is anticipated for a positive response to the treatment. Thank you.